Hi there, my name's Damien. I'm a paediatric emergency medicine consultant from the Leicester Royal Infirmary. I'm going to be talking about the strep surge that happened in December of 2022. This talk is entitled When Fear and Fact Collide, because I think we've got some learning to do about how we communicate with the public, but actually there were some quite frankly terrifying things that happened during this surge, and I think we've got learning from that as well. So I want to start off with a concept. This is something that I think saw on a doctors.net.uk forum, but I can't remember who posted it. And it was actually the low incidence of disease protects the incompetent. That's probably a little harsh, but I think inconsistent is truer. And what this quote is saying is that actually you can do the same thing again and again and again. And if it's a low incidence disease, you can get away. So you could choose not to treat hundreds of children who present to your emergency department without antibiotics. And the vast majority have viruses and none of them will ever come to harm. And that has been true of pediatric emergency medicine for some time. Now, a prototype condition that exemplifies this particular problem is tonsillitis. A child with tonsillitis actually has a relatively low risk of ever coming to harm with that particular condition. Interestingly, though, I don't think that's particularly well understood by the public, and I also don't think it's particularly well understood by clinicians themselves. And one of the things that has come over time is scoring systems or scales or clinical decision systems to help people not give antibiotics to virtually every child with tonsillitis and pick those children that really do need them. And two of those things are fever pain and the Centaur score. And essentially, for NICE, in England, it basically says if you've got low scores, you don't offer antibiotics. If you've got high scores, you do, or you offer an immediate backup prescription. For those of you who can't remember what the difference between fever pain and Centaur is, I've just highlighted it here. And the key thing to remember is that Centaur was done for 15-year-olds, so it doesn't really apply to children anyway. And fever pain was done for 3+-year-olds, so it doesn't apply for your toddlers. And the key thing about this is that in both of the systems, having a cough doesn't get you a point, and points are all win prizes with fever pain and Centaur. Fever pain is out of 5, Centaur's out of 4. But essentially, if you present with big tonsils, which are pustular, you have a short onset of fever, and you don't have a cough, that will put you in the domain of having antibiotics. If you don't really have pustular tonsils, or you've had this for a week, you won't get tonsillitis. You shouldn't get antibiotics for your tonsillitis. And that's basically how the system works. Now, unfortunately, this graph is for adults. There isn't really an equivalent for children, but I'm sure that the same applies for children. And essentially what this is saying is if you take 100 people who meet the threshold for delayed antibiotics or being given antibiotics, only one of them with actual streptococcal sore throat will be given the antibiotic. Lots of them won't have streptococcal infections and won't be offered antibiotics, which is brilliant. But there'll actually be quite a few with streptococcal infections who aren't offered delayed prescriptions. And in this study, none of these people came to harm. And what that shows is that strep carriage, group A strep, or strep pyogenes, is ubiquitous in the population. There's 10-20% of people who have this streptococcus. If I swab their throat, they'll have it, and they may be completely clinically asymptomatic. And that's why there's always this debate, should we be doing rapid strep tests? And the problem is that if we do a rapid strep test at certain times of incidence, all that will tell us is that this patient is a carrier and their symptoms are a bit irrelevant, and that tonsillitis might be completely meaningless. So we do have a challenge here. And that challenge has been taken up by some organisations, and here I'm quoting the Melbourne Children's Hospital guidance, that they just don't give antibiotics for tonsillitis or children with a sore throat. They do give it for certain individual groups, Aboriginals, Torres Strait Islanders, who have a genetic propensity propensity to becoming extremely unwell with group A strep infection. But generally, you basically don't need to treat it unless you've got scarlet fever. Now, the reason they're able to do that is if we take the complications of tonsillitis into context, quinsy, you need to treat thousands and thousands of patients to have an effect. And I think I've also put up here that for mastitis, prostatitis media, that number needed to treat is also huge. So why are we giving antibiotics in the UK for children who are relatively low risk? And my bias around this point is that I've suggested a rule with some colleagues about the fact that you just basically either give immediate antibiotics if you're in a high-risk immunocompromised group, but basically no one else gets antibiotics. Now, the proponents of antimicrobial chemotherapy will really enjoy that, because they will say we'll massively reduce antibiotic use. But some people will say, well, there are some children who do have group A strep or strep pyogenes who will go on to become very unwell, in fact, even die. And we've never really been sure what that group consists of. What are that group? What are their demographics? What are their risk factors? We simply don't know. And this is the reason why we got into such a pickle in December, because we had this disease which we kind of didn't really understand, if I'm honest, in terms of antibiotic delivery. And then suddenly we had a surge of it, and we didn't know what to do. But the magnitude of this surge can't be underestimated. So let's just look at scarlet fever notifications. I'm sorry that this is English data, but essentially it was massive. Now, part of that is because people started notifying when they wouldn't normally do so. So we know lots of scarlet fever goes unnotified. We know we have peaks of scarlet fever, and it's likely that a number of these notifications probably were enhanced by the fact that everyone was aware. But I think this stands out as a particularly impressive notification rate. Now, when the UKHCA started noticing this rise in incidence in late November time, there were also some deaths associated with that. And there is always tragedy in these circumstances. And the UKHCA did have a difficult decision to make. Is they had noticed a trend. They had noticed an increased incidence of scarlet fever and invasive group A strep, and some children were dying. Now, at that stage, it was difficult to know if that death rate was hugely beyond the normative for a strep surge. But it was decided to go live with this on a Friday evening. And the challenge with that is it set up, for those of us working that weekend, a media panic. There was no real voice of reason at the time. The colleges and other organizations were scrambling to catch up, to put out a note of caution. Yes, we were worried. Yes, there was this huge surge, but we didn't really understand what the magnitude of that surge was going to do, and we certainly didn't have any great advice about what we should be doing to deal with it. And so, as the surge went on, and to be honest, this slide is very worrying, because these are laboratory notifications. These aren't things that are kind of made up or subject to subjectivity. What we've got here is notifications from laboratories of group A streptococcal disease in areas of the body it shouldn't be. So in the pleural space, in the meninges, in the bloodstream. And so clearly something was happening in November, December time that was very unusual. And the challenge that came out, and this probably justifies the UKHCA's concern, and the fact that something did need to change, and actually what did change was our microbial prescribing guidance. So what happened is that we reduced in England the fever pain score. So it was 4 and above, it came down to 2, and it made it much easier for professionals to give out antibiotics virtually to anyone who had a sniff of a sore throat or some pus. But what we here have is case fatality rates, and this is all the way up to April of this year. And just to make this table clearer, if you take the lines in 2017 and 2018, you will see that there is a clear difference between the case fatality rate in 22-23. Clearly big, quite a large difference for the 1-year-olds and unders, and quite a significant difference for the 75-year-olds and unders. And then there is kind of a 2 to 3% difference throughout. So there was an excess death. And the question remains is, was that reduced antimicrobial prescribing or threshold, sorry, so we gave out more antibiotics, did that reduce the case fatality rate? So would we have seen more children die had we not done that? Or had we not done anything at all differently, would this have just been a very bad winter? And that's one of the things that's going to be really difficult to unpick from all of this. I do have some Scottish data from pleural empyema cases, very much thanks to Thomas Williams, who's a collaborator on a number of projects I'm involved with, but they just started looking at the huge increase, not in terms of raw numbers, but if you look back on 2017, 2018, they were having kind of 10 more cases a month of different types of empyema, and these are the kind of things that really stand out. And this has a morbidity effect on children. So again, I'm in this equipoise of, we don't want to create panic. We don't want to overload our emergency department, but there was something very real happening here. So why did this happen? Well, there's a number of reasons. One is waning herd immunity. So it's interesting that these waves of streptococcal, invasive streptococcal disease come every 4 to 5 years anyway. The last one was 2017-18, so we were due one at this time. And then because of the lockdown during the pandemic, we had less transmission of group A strep between children and adults. So you've got general less herd immunity, so less protection. We also know because of lockdown, we've got more respiratory viruses spreading, and we know that co-infection with a respiratory virus can make group A strep more virulent. And so we've got this double whammy of reduced herd immunity and more viral co-infections. Now, the last two aren't particularly proven, but we think perhaps there was a change in where strep pyogenes was carried in the body, and also there may have been that this particular strain was more virulent, but there's a bit more work to be done on that. Now, you've heard me mention a couple of times already about this. Well, what do we do about informing the public? How do we let the media know? Well, one of the things that we do is we often talk about red flags in pediatrics. One of my aims is to try and flip these tables around. Why do we always start with red? Why do we always panic parents first? And what we really should be doing is starting all our media messages. These are the things that shouldn't worry you. These are the things that you don't need to do anything about and we expect. And then for the parent listening to that, if that's what they've got, their child's got, in a way that they can turn off because they know that their child's okay. When we start with all the fear mongering and the pale mottled lips, blue lips, the parents start questioning, well, has my child got that? Should I be worried about them having that, etc., etc.? So one of the things I think we need to do is flip our media messaging around to be a bit more proactive about wellness rather than illness. And then the other thing we learned was that we can run out of antibiotics pretty quickly, and the supply chains are very sensitive to quick changes in demand. And it was a bit like toilet rolls during the beginning of COVID. There was a sudden demand for penicillin V and equivalents, and we quickly ran out. And the learning perhaps can be is that more children can take tablets than we thought, and that you are able to crush some of these tablets up. A word of advice to those of you who have children, please don't let them get to be 16 or 17 before they can swallow tablets. It is something 8, 9-year-olds can do, sometimes even younger. But this should be any healthcare professional parent should be getting their children to be able to take tablets. And we should be informing the public about this as well, because this would have been much easier to deal with had we not run out of liquid stocks. And ultimately, the big thing is the need for just good hand hygiene. One of the best ways of preventing the spread of group A streptococcus is doing all the things that we did during COVID, which we sometimes forgotten about. And I'm not talking about everyone masking up and putting gowns on, but basic good hand hygiene, trying to catch sneezes, not coughing over people. These are all the things that we seem to have gone, oh, we did during COVID, and now we can forget about. And we shouldn't forget about that. These are important public health measures. So communication is critical. Please don't launch information at 5 o'clock on a Friday afternoon. It needs to be prepared. It needs to be really well public facing and public judged. I think we need to look at our current guidance for when and if we treat tonsillitis in children and do some kind of public debate on that, and probably more importantly, professional debate. I know I work with colleagues who get quite frustrated with my call for reducing antibiotic use in tonsillitis. Some of them feel that is a bit inappropriate, and that we're risking children's harm. So we've got more debate about that. And then we need to think about overcrowding. So we've had tragedy, like other emergency departments have, of where families have arrived and perhaps they've not been seen in a timely manner, or perhaps they've even left because they've seen the queue is so long and they've taken their unwell child home with them. And that risk of overcrowding cannot be understated. There is clear, tangible mortality for adults, but I think there's a more subtle risk for children. And I think this really exemplified that in December of 2022. It was the highest attendances in England, because I have data for that we've ever seen across emergency departments. And certainly in my department, we went over the 7,000 children in a month threshold for the first time. So those are the key learning points, and I'm now happy to take questions. Thank you very much for your time.